Greetings from CVIR. In this session, we'll give you an interventional radiologist perspective on how to medically manage arterial and venous thrombotic disorders. In this session, we'll look at mainly the drug recommendations with regard to the arterial thrombotic diseases as well as venous thrombotic diseases with specific emphasis on chronic PAD. Starting off with chronic PAD. In general, the prevalence of PAD is on the rise, firstly because of the increased incidence of lifestyle-related diseases, and secondly because we have started to detect a larger majority of them. Now, if you see the risk factors for chronic PAD, you'll see that it parallels to that of coronary artery disease, and that's why many of the treatment recommendations in the earlier periods were actually an extrapolation from the coronary artery data. Now, it's important to note that about 1/3 of patients with symptomatic PAD, if they are not aggressively treated medically, they will succumb to a cardiovascular event in the subsequent 1 year. And that's why the importance of medical management in chronic PAD becomes all the more important. Now, chronic PAD's medical management rests on three main pillars. One is the anti-atherosclerotic therapies or drug therapies that are directed at protecting your vessel, which would also include adjunctive treatments like pain control agents as well as antibiotics if there is wound in relation to PAD. Secondly, risk reduction strategies to treat comorbidities of dyslipidemia, diabetes, and hypertension becomes crucial. And last but never the least is the lifestyle modification, including exercise, tobacco usage, as well as diet control in order for obesity reduction. Now, the understanding that thrombus formation starts with platelet activation was the reason why antiplatelet was being evaluated from since the beginning. And aspirin is one drug that has stood the test of time as one of the most important drugs when it comes to antiplatelet therapy. Now, clopidogrel as an alternative was evaluated. However, though more effective in reducing thrombotic events, was found to have slightly increased bleeding risk when compared to icosapent. Now, the use of dual antiplatelet as well as ticagrelor in the peripheral arterial bed has found to be not guided by evidence in literature, though both of these are largely useful in the coronary artery data. Now, beyond doubt, across all guidelines, it's known that an antiplatelet is essential in CLTI. Now, people thought, then why not add an anticoagulant as well? And that's why initially there was an evaluation of warfarin to offer any advantage. However, life-threatening bleeding was found to be increased, and that's why across guidelines the use of vitamin K antagonists for chronic PADs is not recommended. However, the arrival of your newer oral anticoagulants have changed the picture to what we stand now or presently with the dual pathway inhibition. Now, the principle is your thrombus formation starts either via the platelet and the platelet aggregate as well as via thrombin generation from factor 10A that induces the inflammation and the vessel changes that finally leads to atherosclerotic thrombus formation. And naturally, you inhibit it at the platelet level as well as at the thrombin level via the newer oral anticoagulant to give you the dual pathway inhibition. Now, this has been evaluated across trials with the second last being the COMPASS trial, which proved beyond doubt the advantages when it comes to major adverse cardiac events, though there is a slight increase in bleed. This was also proven beyond doubt with the Voyager PAD study that also showed significant advantage when it comes to major adverse cardiac event rates as well as limb event rates when compared to a non-significant increase in major bleeds. Now, there were also drugs that evaluated to increase the circulatory changes at the microscopic level in the ischemic bed. So the agents that included were pentoxifillin, silastazole, and the relatively recent naftalfuril, of which silastazole is found to be the most effective presently. Now the importance is that silastazole is contraindicated in heart failure patients, as well as it requires dose reduction in patients with liver dysfunction as well as who are on enzyme inhibitors. Presently, data to the widespread use of naftalfuril is not available to warrant its use in chronic PAD at present. Now, other agents that have been evaluated but still data is insufficient for widespread use is one is evalucumab, which is an add-on to your statins to reduce LDL levels, Vorapaxar, which is an add-on to your antiplatelets, as well as other agents like homocysteine lowering agents, which are basically found to be not very useful. However, because they are multivitamin drugs, there is no harm in trying the same in the spectrum of patients. The other agents like defibrinating agents and stem cells are also awaiting further results from research that is ongoing for widespread use. Now, the motto is not only with regard to live longer, but also live better. And that's why in patients with pain, pain control medications are paramount, of which paracetamol and opioid, namely tramadol, is the drug of choice and the one that is widely used. Now, whenever you're using opioids, they are likely to cause constipation and nausea, and therefore medication to prevent the same becomes important. Alternatives like tricyclic antidepressants, gabapentin and pregabalin can also be added if pain is not controlled with the former combination. The latter drugs can also be used in treatment of neuropathic pain as well. Now, prostanoids in chronic PAD has been evaluated across trials, and they have found that they do not offer long-term benefits. However, there has been reports of reduction in rest pain and improvement in ulcer healing in about 1/3 of patients in most trials. And that's why, though there is no recommendation to the use of these drugs in many of the guidelines, the ACC/AHA guidelines do mention them in order for reduction of rest pain and improved ulcer healing. Risk reduction with treatment of your comorbidities like dyslipidemia with statins, wherein the Jupiter trial has clearly shown the cardiovascular advantage, states that your statin is indicated irrespective of cholesterol levels in all PAD patients, and they require high intensity statin therapy with your 40 mg atorva or your 20 mg of rosuvastatin. Dose reduction may be vital if the patient has incidence of myopathy. Hypertension control with a target that's less than 140/90, of which AC inhibitors are the primary drug of choice, and metformin with a starting dose for diabetes mellitus control can be considered. Now, sodium GLUT2 inhibitors, though said to have an advantage with regard to cardiovascular events, have been found to have an increased incidence of limb events and therefore not generally recommended for this purpose. Now, the most important level 1 recommendation is actually exercise for these subset of patients, and they increase the circulation by causing enlargement of the collateral vessels as well as angiogenesis and vasodilation, in addition to other mechanisms as well. Even within this, an institutional based 12-week program is found to be the most effective in reduction of symptoms of the patient, and that too, whenever exercising, it's vital that you advise the patient to stop the exercise only at the maximum tolerated claudication pain and not at the onset of claudication itself. And across all modes of exercise, when they have compared swimming, cycling, jogging, it's actually plain brisk walking that is found to be most effective, and that too at least for more than 30 minutes, that too at least for 3 days a week. Now, coming to the drug recommendations, so this is an amalgamation of the various guidelines that have come over time. So every patient with a PAD will fall into one of these spectrum. Either they can be asymptomatic, they can be intermittent claudication, or with the onset of rest pain, patient may be categorized as CLTI. When it comes to asymptomatic PAD subgroup, this is a subgroup where literature is deficient with regard to drug regimens. Therefore, the use of the dual pathway inhibition may be decided upon by the clinician based on the risk assessment of individual patients. With regard to risk reduction, the role of statins, there is a controversial relevance because irrespective of cholesterol levels, statin therapy has found to have an advantage and therefore probably may be a wise choice when it comes to treatment of these patients. Definitely you need to screen these patients for diabetes, hypertension as well as dyslipidemia. Lifestyle modification with exercise, diet and obesity control with a BMI less than 25 and smoking cessation, even considering the use of varenicline for the same in addition to education and counseling, becomes vital. Now, these subset of patients generally do not require surveillance, but you need to educate them with regard to the signs and symptoms. You can keep the patients who are higher risk patients like diabetic patients or patients who already have a lower baseline ABI on follow-up if you need to check for progression. When it comes to intermittent claudication, your dual pathway inhibition becomes crucial in addition to the use of vasoactive agents, and to a degree your homocysteine lowering agents can also be tried. Now the risk reduction remains the same with the target LDL of less than 100 or less than 70 depending upon the risk, and even in the recent cardiac guidelines even up to less than 55 is warranted. The diabetes and hypertension control remains the same as briefed earlier. The lifestyle modification also remains the same. Now these subset of patients, in addition to all these drugs, would also need a pain control as was also summarized earlier. Now these subset of patients do require annual follow-up in order for checking for compliance of these regimes as well as for disease progression by itself. If you see intermittent claudicants, only a minority of them will start to have or progress to have a critical limb ischemia. The larger majority will have a stable claudication per se. And that is why in general, whenever you are trying for medical management, any duration from about 3 months to 6 months, a trial of smoking cessation, your risk reduction, your lifestyle modification is warranted before proceeding to any invasive therapy in the subgroup. Now, when in CLTI, the salvage of a functional limb becomes important. So your dual pathway inhibition, your vasoactive agents, homocysteine lowering agents, and prostanoids, wherein to reduce your rest pain and wound healing may be warranted. The one that is used in our institute is PGE1 or alprostadil at a dose of 100 to 166 microgram per day infusion over 8 hours, which can be followed for a 3-day or a 5-day regime depending upon your institutional protocol. The risk reduction as well as the lifestyle modification remains the same. Now, these patients, in addition to pain control, would also require wound care, which includes your antibiotic and hyperbaric oxygen therapy. Now, coming to acute limb ischemia, the acute limb ischemia patients, whenever diagnosed initially, would require the initiation of heparin, which is a class 1 recommendation, in addition to your IV hydration and supplementary oxygen. The use of adjuvant prostanoid treatment is a category 2B evidence. Systemic thrombolysis is a definite no when it comes to treatment of ALI. Now, these patients would also require pain control, can consider lowering of foot end of the bed, as well as management to prevent compartment syndromes as well. Post your CDT or surgery, depending upon the clinical status of the patient, the continuation of anticoagulants, antithrombotic or statins depends upon the underlying etiology. So if the patient has AF or an intracardiac thrombus, or the patient has an occluded prosthetic bypass, these are the patients who generally or definitely require an anticoagulation. Smoking cessation also becomes vital in these subset of patients. Now coming to the venous spectrum, of which DVT. So treatment with an anticoagulant is essential in proximal DVT, though controversial also in distal DVT. Cancer-associated DVT requires the use of low molecular weight heparin, and superficial thrombophlebitis also requires to be treated in the same lines of DVT if the superficial vein which is thrombosed is within 3 centimeters of its junction with the deep veins. If the vein is more than 3 centimeters away but having a thrombus length that's more than 5 centimeters, you need to give at least an intermediate or a prophylactic dose of your anticoagulant as per the recent recommendations. Now, in general, you start the patient on an unfractionated or a low molecular weight heparin for the initial 5 to 10 days, depending upon which oral agent you are shifting to on the long term or the extended period, depending upon the underlying etiology of your DVT. Now, the point to be highlighted is that rivaroxaban and apixaban does not require the initial 5 days of heparin bridging in order for its anticoagulation dosage. Now, coming to post-thrombotic syndrome, in general, the proven benefits are there for compression, that too with short stretch bandages and multi-layered or multi-component systems. In addition to exercise, leg elevation and smoking cessation may also be useful. Now, anticoagulation beyond what is required for DVT is generally not recommended. Diuretics can be added to reduce edema in the lower limb, and antibiotics if there is any infection in the wound secondary to PTS that has to be effective against staph as well as streptococcus species should be considered. The wide variety of vasoactive drugs that are generally used by all IRs are generally, as of now, having insufficient data regarding its effectiveness in general. So to conclude, drugs and more importantly exercise is crucial adjuvant in your interventions. Dual pathway inhibition is now the standard of care in chronic PAD. With the arrival of your newer oral anticoagulant, venous thrombotic management has changed a lot. And yes, medical management is definitely crucial if your overall as well as long-term survival of your patient is the need. Thank you.